This is Dr. Ganga. Today, let us learn about thrombotic microangiopathy. So, if you see this word, that itself means thrombotic. That means there is thrombus formation, where in the micro circulation, that is microangiopathy. So, in this chapter, we learn where and all these thrombus are formed, in which microcirculations, and what is the cause and how to treat this. So, we'll learn this chapter under the following headings. First, we'll see the normal complement pathway. We'll see the definition of thrombotic microangiopathy. Then we'll deal with the two types of thrombotic microangiopathy, which is HUS, that is hemolytic uremic syndrome, and TTP, that is thrombotic thrombocytopenic purpura. We'll learn the laboratory features of the disease, mechanism by which this disease occurs, diagnosis, what are the clinical features, treatment, what are the types of HUS, and also we learn about TTP. And finally, we'll finish up with high yield questions, which are important points that is required for revision just prior to the exam. Now, coming to the complement pathway, there are three important ways in which the complement pathway gets triggered in the body or stimulated in the body. First is classical pathway, second is alternative pathway, third is MBL pathway. Okay. Now, first focus only on this section, that is classical pathway. What happens in classical pathway? In classical pathway, there should be activation of the complement system. In complement pathway, there should be activation of the complement system by an immune complex. That is, there is an immune complex, that is antigen and antibody. The C1q, which is present in the circulation, comes and binds to the Fc portion of this immune complex and gets activated. Right? Now, once this gets activated, it activates the important components of the complement series going further down. Okay. So, first, which starts with C1q, it goes and stimulates C4 and C2. Okay. Now, this gets sliced into two components, C4b and C2b combined together, and it forms something called as C3 convertase or classical pathway C3 convertase. So, this is going to, this is an important step. Now, this further will go and act on C3. Here you can see it is going and acting on C3. So, C3 will produce two important components. First is C3A, which acts as an anaphylatoxin, and C3B. Okay, this C3B is important in activation of C5. So, C3b has two functions. First is it acts, helps in opsonization, that is bringing about other leukocytes into the area where complement is activated. The second function is it goes and binds to C5 convertase and forms a C5 convertase, that is it binds to the C4b2b already, which is formed, and it is going to go activate this C5. Okay. This C5 once activated forms two things. First is C5a, which is chemotactic factor, and next is C5b, which activates C6 to C9. So, this together, C5b to C9 together will form membrane attack complex, which does the final mechanism of destroying the foreign body. So, this is the classical pathway. Classical pathway will get activated only in the presence of immune complex, and the complements involved in classical pathway are C1, then C4 and C2, which forms the C3 convertase, then C3, then C5, then C5 to 6 to 9. Okay. So, this is the way. So, if classical pathway is activated, then when we check C3 will be low because here it is getting utilized, and C4 also will be low. Okay. So, this is the first pathway. Let's go to alternative pathway. Okay. Alternative pathway can get activated by itself, or it can get activated by multiple mechanisms, that is the presence of bacterial polysaccharides or injured cells or aggregated IgA and endotoxins. So, all these things can trigger alternative pathway. So, circulating auto-activated C3b binds to activating surface, okay, on all these cells. Now, once what happens, this forms C3b. This C3b with the help of factor B and D forms an important thing called C3 convertase. This C3 convertase is nothing but the activation product of C3b and factor B. So, it is C3b and factor B. Okay. Now, this goes and activates C3. It produces C3a and C3b. C3a acts as anaphylatoxin. C3b again binds with this along with propyridine, causes to form C5 convertase. Now, next one C5 convertase is formed. The pathway is same. That is, it is going to form a membrane attack complex which is C6 to C9. So, here we see the only important complement factor is C3. Okay. C3 along with factor B. Now, once C3 is formed, it is going to go and act on 5 and then 5 to 9. So, in an alternative pathway, how will we know that alternative pathway is activated in the body? So, if only when we do investigation, only if C3 is low and C4 is normal, then it means it is alternative pathway activation. Next is mannose binding lectin pathway. Mannose binding lectin pathway, the structure is similar to C1q and it is going to bind to the bacterial cell wall. Okay. So, this goes and acts on C3, same thing, forms C3b, C3b binds to, this goes and acts on C3, forms C3b, again there is formation of C3 convertase, C5 convertase and finally membrane attack complex. Okay. So, this is about the complement pathway. Now, definition of thrombotic microangiopathy. Okay, there is lesion of the arteriolar and capillary vessel wall. It is microangiopathy. That means microcirculation or micro vessels are involved. Which are the micro vessels? Arterioles and capillary wall. Okay. So, what is the disorder or the lesion that is seen? There is thickening of the vessel wall with intraluminal platelet thrombus. So, if this is the vessel wall, this is the endothelium, there is thickening of the vessel wall, okay, along with intraluminal platelet thrombus. This can completely occlude the vessel wall, okay. So, basically in every area it is impeding the blood flow, okay. So, this is the main mechanism. Now, this is about the definition. What are the types of thrombotic microangiopathy? The types of thrombotic microangiopathy are two. First is HUS, also called as hemolytic uremic syndrome. The second one is TTP, also called as thrombocytopenic purpura. Okay. So, these are the two types of thrombotic microangiopathy. So, what is HUS? What are the etiologies of HUS? So, there are two things that are caused by infection and one that is not by infection. The first one is STEC-HUS, that is, ST is Shiga toxin. It's a very powerful toxin that is produced by STEC E. coli, that is Shiga toxin producing E. coli, and also by Shigella dysenteriae. Okay, so there are Shigella dysenteriae and Shiga toxin producing E. coli that is causing this Shiga toxin. So this is Shiga toxin producing E. coli induced HUS. Second is HUS associated with Streptococcus pneumoniae. Streptococcus pneumoniae is another infection where 40% of cases of HUS is seen to be because of this. The third is atypical HUS, which can be because of a familial or a genetic deficiency of any of the factors of the complement system like factor H, or excess activation of the alternative complement pathway. Now, what are the features that we see in HUS? Okay, so imagine this situation. There is a blood vessel and there is damage to the endothelium. Okay. Once there is damage to the endothelium, there is formation of the thrombus. This thrombus contains what? It contains platelets plus RBC plus fibrin, right? That is what this microthrombi is formed by, nothing but platelet and RBCs coming together in a fibrin clot. So what is going to happen? This RBC is going to lyse, right? So there is going to be hemolysis, what we call as microangiopathic hemolytic anemia or MAHA. Okay, microangiopathic hemolytic anemia, right? So there is going to be anemia. Okay, next thing, platelets are also present in this clot, right? So imagine this, I'm just showing one vessel. Like this, thousands of blood vessels in the body can be affected. So platelets are going to be there here. So these platelets will get destroyed and cause thrombocytopenia. Okay, so that is the second condition that will be seen. And in HUS, it is seen that this involvement is majorly seen in the kidney. So all the kidney, that is glomerular, the arterioles or capillaries in the kidney are glomerular capillaries. All the glomerular capillaries are going to be affected, causing severe AKI. So these three are the major manifestations of HUS. Okay, so you can see that. Now this disease earlier was divided into D plus HUS and D minus HUS. That is, anything that is associated with STEC was called as D plus HUS. That is, patients will have diarrhea along with HUS. Okay, D minus HUS was the atypical HUS. But as of now, it is not called anything. It's called HUS or atypical HUS. So this HUS is commonly seen in children less than 5 years of age. Okay. And the most common organism causing it is STEC, that is Shiga toxin excreting E. coli, okay, or secreting E. coli. But this happens in isolated pockets. If it is happening in epidemics, then it can involve any age group. It will not stay isolated to one age group of less than 5 years. It can happen to any age group, okay. So one such epidemic that happened in Germany was by E. coli O104H4 strain, where adults were seen to be more affected than children and women were affected more than men. Okay, so this is about STEC. The second group is Streptococcus pneumoniae, which is responsible for 40% of childhood HUS. Okay, and atypical HUS, its incidence is less, it's only 10%. But it is very severe. That is, without giving treatment, 50% of the patients progress to ESRD. So this is about atypical HUS. Now coming to TTP. TTP is similar to HUS, but this comes with an important pentad. That is, along with microangiopathic hemolytic anemia, thrombocytopenia and renal failure, there are two additional involvement, that is fever and neurological involvement. In fact, in thrombotic thrombocytopenic purpura, the kidney involvement is lesser, brain involvement is more. Okay, so neurological involvement is a very important feature of TTP, and fever also occurs. So this is called as pentad of TTP. Okay, this is very important. This can come as an MCQ not just in nephrology but also in the medicine part. Okay, though it is a non-infective condition, fever can happen. So it is easy to get confused with this point and miss this in the options. So please remember that fever is also there. Okay, this can occur at any age, and neurological symptoms is seen in more than 90% of the patients. This happens because there is thrombo-occlusive disease of the grey matter. See, in HUS, the etiology is such that it whatever is the toxin that is affecting has its propensity to go and get attached itself to the kidney. Okay, so kidney involvement becomes more common, but in TTP that is not seen. The mechanism is such that it can involve all blood vessels, and preferably brain, more so brain involvement is seen. So more than 90% of patients will have neurological involvement, and neurological sequelae might persist in these patients. Now, laboratory features that you see in TME, microangiopathic hemolytic anemia. That means there is going to be presence of schistocytes. Already I explained about this. So once hemolysis is seen, what is going to happen? Bone marrow is going to get stimulated. So this is going to increase production of RBCs. So there is going to be increased reticulocytes. So reticulocyte count is elevated, okay? And peripheral smear shows increased schistocytes. And then hemolysis in the blood will increase the LDH, and because there is lot of free iron that is present in the blood, haptoglobin binds to them all and free haptoglobin level reduces. So LDH increases and haptoglobin reduces. Since it is not immune mediated hemolysis, Coombs test is negative. The hemolysis happens because these RBCs get accumulated in this clot and it gets sliced. It is not because of immune mediation. So Coombs test becomes negative. Okay. Thrombocytopenia happens because in the platelet rich thrombus there is destruction. And once there is thrombocytopenia, similarly there is bone marrow activation and there is release of platelets into the circulation, okay, or giant platelets in the peripheral smear. There is bone marrow activation which releases giant platelets, okay. So this is what is seen with thrombocytopenia. So hemolysis and its associated features, thrombocytopenia, while having negative Coombs test is a characteristic feature. Now, when we do complement level, C3 level is low. Later, we will see that C3 is an important thing which initiates this, okay, because C3 is not regulated, C3 is getting activated excessively only, these problems happen. So, C3 is going to be low and coagulation profile is going to be normal, that there is not going to be anything like a DIC, that it's all small thrombus. So, there is no consumption of all these, it's actually a platelet rich thrombus. So, there is no consumption of coagulation factors like in a venous thrombosis, right? Then renal involvement is seen in all patients with HUS and only 25% of TTP. So, kidney involvement is seen in almost all patients of HUS, but whereas only 25% of patients of TTP have kidney involvement. Okay. Now coming to pathology, there is microvascular thrombosis of various organs. Okay. So various organs, there is thrombosis. Then there is widening of the subendothelial space. If this is a subendothelial space, there is so much inflammation that this space gets widened. Okay. And there is thrombi formation that we already know, and this will trigger inflammation. So leukocytes are going to be present. Okay. So leukocyte infiltration is seen in this area. So if you see a cut section, this is what you are going to see in a patient with TMA. Now in kidney, what happens if these blood vessels are getting necrosed, then there will be patchy cortical necrosis that is seen. Eventually, this cortical necrosis, the other part of the other kidney has to compensate and it forms FSGS. Okay, this is the pathology of kidney involvement in TMA. Now, this is when it comes to gross and light. What happens in electron microscopy? I told you there is subendothelial deposition of materials, right? So, this subendothelial material, so there is swelling and detachment of the endothelial cells from the basement membrane. This is for the material to deposit. The endothelial cells get swollen and it gets detached from the basement membrane. Okay, and there's a fluffy material, that is the inflammatory material, which gets accumulated in the subendothelial space. This is the same thing that we saw in the previous slide. Okay, then there is intraluminal platelet thrombus causing obstruction of the vessel wall. So this is the characteristic electron microscopic picture that is seen in thrombotic microangiopathy. Now, not just in thrombotic microangiopathy, any disease that causes severe injury to the endothelium will have this presentation, like scleroderma, malignant nephrosclerosis, chronic transplant rejection and CNI nephrotoxicity. So, a picture in electron microscopy that is suggestive of TMA will be seen in HUS. See, TMA is mostly a pathological diagnosis. These are the main causes. Okay, HUS, TTP, scleroderma, malignant nephrosclerosis, rejection in the kidney and CNI toxicity. Okay, so these three are the 6 causes of TMA that we see most commonly in nephrology. Now, coming to each specific type. First one is STEC-HUS. Okay. Now, this STECHUS is by a Shiga toxin producing E. coli or Shigella dysentery, both of which produce Shiga toxin. Now, once ingested, this causes gut infection and its effect on the gut epithelium causes diarrhea, which is bloody. Okay. The source of this E. coli or Shigella dysentery is mainly in the cattle, but in the cattle, there is absence of cells which binds Shiga toxin. So, cattle are going to be free of disease. But if people are going to eat undercooked meat or vegetables and fruits that are extracted from the garden which has the cattle excreta and which has not been cleaned properly. So, this is the way by which E. coli and Shigella dysentery is going to enter the systemic circulation, okay, enter the gut. Now, what happens is these organisms, once it enters the gut, it destroys the gut epithelium, causing diarrhea, right? Then these organisms are going to bind to gut epithelium. Once it binds to the gut epithelium, it undergoes transcellular shift into the cell and to the circulation. Okay. So, in the cell it is going to release this Shiga toxin, right? The toxin is going to get accumulated in the circulation. Once the toxin is in the circulation, it is going to bind to neutrophils that are present in the blood. So wherever these neutrophils go, it is going to carry these toxin and it is going to go to those particular organs. So whichever organs have an affinity to bind to this neutrophil Shiga toxin complex is the one which are affected. So in the kidney, what happens? It binds to the GB3 receptor that is present in the endothelium, in the podocytes and tubular cells. Okay. So this is what happens once it enters the kidney. It binds to all these three cells, and once it binds to these cells, it is going to inhibit protein synthesis. Okay. It is going to inhibit protein synthesis, and finally there is accumulation of leukocytes, activation of complement and destruction of cells. Okay. So, all this is going to lead to thrombi or platelet plug formation. Okay. So, this is the mechanism by which this Shiga toxin is going to cause kidney damage. Okay. Now, diagnosis is stool culture can be done to see this Shiga toxin producing E. coli or Shigella dysentery, and in the convalescent phase, the antibody can be tested in the serum to come to a conclusion or diagnosis. Okay. So, coming to the clinical features. So, first E. coli is ingested. Okay. Within 3 to 4 days, patients are going to have abdominal cramps and non-bloody diarrhea. Okay. Imagine 100 patients are ingesting it. Within 3 to 4 days, they are going to develop abdominal cramps and non-bloody diarrhea. Out of which only 70 to 80% of patients, that is also very significant number, they are going to develop bloody diarrhea. So, 1 to 2 days later, 70 to 80% of patients are going to develop bloody diarrhea. The other symptoms that they are going to have is vomiting, which is seen in 30 to 60%, and fever around in 30%. So, it's not very important to remember these numbers. I have just put the numbers to show the significance. That is, maximal patients are going to have bloody diarrhea and few are going to have vomiting and fever. Okay. Now, out of patients who develop bloody diarrhea, 95% undergoes resolution in 5 to 7 days. That's a very good news that 95% of them resolve. Okay. And 5% of patients are the ones who are going to develop HUS. 5% of these 70 to 80% of patients are the ones who develop HUS. Okay. So, in the patients who develop HUS, dialysis requiring patients are around 40 to 50%. Okay. Recovery is seen in more than 90% of patients. ESRD in long run was seen in around 12% of patients. That is very less number. You can approximately remember it as 10% if it is difficult to remember otherwise. And death is seen only in 1 to 2%. So, once the bacteria is ingested, it is going to cause diarrhea, out of which bloody diarrhea will be seen only in 70 to 80% of patients. So, this itself, for the bloody diarrhea to happen itself, will take 5 to 6 days. Once the bloody diarrhea happens, in 1 week's time, it can either undergo resolution or develop HUS. 95% of patients undergo resolution, 5% of patients develop HUS. In the 5% of patients who develop HUS, around 50% require dialysis, 12% develop ESRD in the long run, and 1% die. So, this is how the clinical features of STEC-HUS. Now, treatment. The only treatment is IV isotonic volume expansion, because there will be endothelial damage, there will be third spacing. Prerenal AKI should not, any hypovolemia can cause prerenal AKI and worsen this condition. So, volume expansion should be given. If there is severe anemia, RBC transfusion. Bowel rest should be given. Anything that prevents further entry of the bacteria into the circulation should be done. Okay. Anti-motility drugs should be avoided, because these bacteria won't get removed out. It will stay in the gut and it will cause problems. So, anti-motility drugs should be avoided. Okay. Now, antibiotics are contraindicated in Shiga toxin HUS. This is a very important point. In the treatment of Shiga toxin associated HUS, antibiotics cannot be used because it increases the risk of HUS by 17 times. What antibiotic does is it causes injury to the bacterial wall. Okay. So, whatever is the toxin that is present inside the bacterial wall comes outside into the circulation if the bacterial wall gets affected. So, it will worsen HUS. Okay. And quinolone and trimethoprim especially. Quinolone is a common drug that is used in diarrhea. That is going to induce the Shiga toxin producing gene in the bacteria. So, that also should be avoided. But in Shigella dysentery, it might be helpful. This is in E. coli. Okay. In Shiga toxin E. coli, that is STEC-HUS, antibiotics are absolutely contraindicated. Other treatments like plasma exchange can be tried, especially in adults with neurological involvement and AKI. Transplantation can be tried in children progressing to ESRD. Recurrence rate is less, 0 to 10%. Unlike in atypical HUS, where recurrence rate is almost 90 to 100%, the use of eculizumab is not clarified. So, basically, volume expansion is the only thing, and symptomatic therapy. Do not give antibiotics in STEC-HUS. Okay. Now, HUS because of Streptococcus pneumoniae. HUS because of Streptococcus pneumonia. Streptococcus pneumonia can cause pneumonia or meningitis. Okay. Neuraminidase cleaves the glycoprotein from the cell membrane of the cells. Okay. Mostly RBC. So, what will happen? It is normally an antigen called as T antigen is hidden in the cell. So, this neuraminidase goes and exposes this T antigen. So, normally the anti-T antibodies which are present in the blood are going to act on this, and it is going to cause destruction. Okay. So, that is what neuraminidase, it cleaves the glycoprotein from the cell membrane of the cell and exposes the normally hidden T antigen, and it reacts with anti-T IgM in the blood. Okay. So, because this is antigen antibody mediated reaction and hemolysis, Coombs test is going to be positive in these patients. Now, clinical features and treatment. In less than 2 years, there is going to be severe illness. Mortality rate is around 25%. Okay. So, it is more severe than what is seen by Shigella toxin E. coli. Antibiotics are to be given, because here the only way you can curtail the thing is by killing the Streptococcus pneumoniae. So, antibiotics has to be given. Plasmapheresis is contraindicated because plasmapheresis involves infusing new plasma into the patient. So, what will this new plasma have? This new plasma will have more anti-T antibodies, right? So, because this is seen normally in all human beings. So, this is going to further worsen the condition, right? So, you are not going to do plasmapheresis. So, we saw that in STEC-HUS, antibiotic was contraindicated, whereas in Streptococcus pneumoniae HUS, plasmapheresis is contraindicated. Okay. Now, next thing that is to be done is washing of RBCs. Washing of RBCs so that the effect of this washed RBCs can be given so that this this T antigen is not visible and anti-T antibodies cannot act. Okay. So, this is about Streptococcus pneumoniae causing HUS. Now, coming to atypical HUS. In atypical HUS, there is genetically determined complement dysregulation. Okay, complement dysregulation is genetically determined. It is usually sporadic and only less than 20% are familial. Okay, now what are the precipitants which is going to precipitate HUS? It can be a bacterial infection or a viral infection. It can be drug like calcineurin inhibitor. It can be malignant hypertension, that is in severe hypertension there can be effect on the endothelial wall. Okay, so that itself can act as a trigger for TMA. In transplantation, patients receiving cyclosporin more than tacrolimus and pregnancy, all these act as triggers for development of HUS. Now, if you see this chart, it is just revision of the mechanism that we already discussed. Classical pathway, there is requirement of formation of immune complex. C1q is the one which goes and recognizes this. So, this acts on C4 and C2, forming C3 convertase, which is C4b and C2b. Then this C3 convertase acts on C3, produces C3a and C3b, which forms C5 convertase, which acts on C5 and producing the membrane activating complex, right? Now, in the alternative pathway where it can be activated by bacteria or bacterial toxin or takeover, that is automatically by itself, it goes and acts with factor B and forms C3 convertase, which is C3b-BB, right? Then this further binds to form C3b square BB, which is C5 convertase. With the help of piperidine, it's going to act on C5. The mannose binding lectin pathway also follows like the classical pathway. Now, this is how the automatic activation of C3 happens and how it is prevented. Okay. Once C3 is there, it is acted upon by factor B and factor D. Okay. It forms alternative pathway initiation C3 convertase. That is, this factor B goes and binds to any C3 it finds and it goes and activates C3. So, this is alternative pathway initiation C3 convertase. Now, once this forms, this along with factor B is going to form C3 convertase for the C5 convertase. Now, there are factors in the blood which is going to prevent this, right? Otherwise, this is going to go on propagating and it is going to cause problem. So, in the blood, there are three important components: factor H, factor I and MCP, okay, and MCP, which is membrane cofactor protein, okay. So, this factor H, factor I and membrane cofactor protein are one which goes and inactivates this C3b formation and also dissociates the C5 convertase, C3 convertase, okay. So, this is the function of complement factor H. Similarly, here you can see when there is a bacteria or any activating surfaces, the C3b with the help of factor B, piperidine and complement factor D forms amplification loop C3 convertase, going on increasing the production of C3. Okay, here also this comes into check and here also this comes into check. Okay, so basically the factors which inhibit C3b activation or inhibit the automatic activation of C3 are C5 complement factor H, complement factor I and membrane cofactor protein. The factor which triggers it are C3b, factor D and factor B. All these things are important because the mutations in this, either it will be loss of function mutation or gain of function mutation which is causing HUS. Okay. Now, here if you can see here what is the disease and what is the etiology. That is, in a HUS, if Shiga toxin associated, it is infection by the Shiga toxin producing bacteria, and in neuraminidase associated, it is by Streptococcus pneumoniae. Atypical has multiple. It can be either familial or sporadic. Okay, under sporadic there are multiple headings. It can be idiopathic, it can be pregnancy associated, it can be transplantation associated. So, under familial, the most common here you can see is complement factor H mutation. Okay, this is the most common. Apart from this, there can be factor I mutation, C3 mutation, MCP, complement factor B. Okay, so these are the ones, and there are also complement factor H or HR. These are complement factor H related protein, which generally what it does is it inhibits the factor H. Okay, so the mutations in this also can lead to HUS and diazyl glycerol kinase mutation. Okay, so this is familial. Then when it comes to sporadic, which is idiopathic, complement factor H is 15 to 20%, rest all are present, the same type of mutation. In an anti-factor H antibodies is 6 to 10 when it is idiopathic. In pregnancy associated, again most common is complement factor H. So, complement factor H is most common in familial, then idiopathic, pregnancy associated. Okay. In health syndrome, factor I is seen at 20% and factor H is seen at 10%. Similarly, in transplantation, also factor H and factor I is almost equal. So, in these three conditions, we see that factor H mutation is most common, that is familial, idiopathic and pregnancy. Now, what happens if each of these factors are affected? Okay. So, if it is complement factor H mutation, this these tables are taken from Fihali textbook, 6th edition. So, you can refer to the textbook also. So, complement factor H is where factor H is affected. So, what happens here is the frequency of atypical HUS, you can see most common is because of factor H mutation. Okay. Rate of remission with plasma exchange here is 60%. That is pretty good. Okay. 5 to 10 years ESRD risk is high, that is 70 to 80%, and recurrence rate after transplant is also high. So, you can see factor H, there are three most important things. First is, it is the most common type of atypical HUS mutation. Second is, ESRD risk is maximum with factor H mutation. Third is, recurrence after transplantation is also maximum with factor H mutation. So, these are the three important things of complement factor H mutation. Okay. Second one is factor H related protein 1 and 3. Okay. And also anti-factor H antibodies. Here the frequency is only 5 to 10, but plasma exchange when it is done, remission rate is good, 70 to 80, especially when anti-factor H antibody is there. If we give immunosuppression along with that to suppress the production of anti-factor H antibody, then the remission rate is good. Okay, the ESRD risk is 30 to 40% and recurrence rate is also 30 to 40%. Next thing is membrane cofactor protein. Membrane cofactor protein is when there is no surface. See, the thing with membrane cofactor protein is it is a cell bound component. Okay, so if we do plasmapheresis, then this is not going to be removed, because plasmapheresis is just not going to remove protein or cell bound component. So there is no indication to plasma exchange. The frequency is also less. See, but the most interesting part about it is, plasmapheresis cannot be done in these patients because plasmapheresis will not help. But the rate of ESRD in them and rate of recurrence is very less. So, if they ask the type of mutation with least risk of ESRD, it is MCP. Similarly, the type of mutation with least risk of recurrence, it is membrane cofactor protein. Okay. So, this is with membrane cofactor protein. Next is factor I. Okay. Complement factor I acts along with factor H in causing inactivation of C3 convertase or inactivating C3b. Frequency is less, only 4 to 10%. Rate of remission with plasma exchange is 30 to 40. Rate of ESRD and recurrence is high. Okay. So, all these are loss of function mutation. Next is complement factor B. This is a C3 convertase stabilization is its function. So, gain of function of this, the mutation is just 1 to 2% frequent. Its rate of remission with plasma exchange is less, that is 30, and 5 to 10 year rate of ESRD is 70. Similarly, there might be resistance to inactivation by resistant to C3b inactivation. Its frequency is 8 to 10%, with rate of remission being around 40 to 50% while doing plasmapheresis, and ESRD risk is 60%. Okay, thrombomodulin is another mutation also which is very rare with high rate of ESRD. So from this table, it is okay if you can't remember the numericals. What you have to remember is which is most common, which is least common. Most common is factor H. It is most common for three things. One is the most common mutation that is causing atypical HUS. The most common or most virulent to cause ESRD is factor H. The relapse after transplant also maximally seen in factor H. And least is membrane cofactor protein or MCP. Here plasmapheresis is contraindicated because this is bound to the membrane. Because doing plasmapheresis is useless. Rather than contraindicated, we would tell useless, because anything that is membrane bound cannot be removed by plasmapheresis. While its chance of this progression to ESRD is only 15%, and chance of recurrence after kidney transplant is also less than 15 to 20%. Okay. Now coming to the clinical features. This is seen of atypical HUS. This is seen mostly during the childhood. Patients present with same thing, hemolytic anemia, thrombocytopenia and AKI. Extrarenal involvement is seen in only 20% of patients. Okay. Now treatment modality. When it comes first, there are four important treatment modalities. First is plasmapheresis. Plasmapheresis is the gold standard. It is better to start with within 24 hours of diagnosis. Okay, and if patient has anti-complement factor H autoantibodies along with plasmapheresis, it is important to add immunosuppression, because that is going to prevent the production of anti-complement factor H antibodies. Next, if there is MCP mutation, then this plasmapheresis is not beneficial, and 80% of patients undergo spontaneous remission. So there is no need to do plasmapheresis in these patients. Okay. Now second is kidney transplantation. Kidney transplantation, high frequency of recurrence is seen with graft loss seen in 80 to 90%, especially in complement factor H, I, factor B and C3 mutations. Okay. Lowest incidence is seen in membrane cofactor protein and diacylglycerin kinase mutation. Okay. Live related donation is contraindicated. That is, any person related like mother, sibling should not donate, because these are mutations. The relative also might be carrying the mutation, and the moment nephrectomy is done, that trigger itself can precipitate HUS in the donor. So we cannot allow this to happen. So live related donation is contraindicated. Next is eculizumab. Eculizumab, which is a complement inhibitor, which is a C5 inhibitor, can be used to induce and maintain remission. See, because in the pathway, the final step is activation of C5, right? So if we stop that, then all the further damage can be prevented. So it can induce remission, maintain remission. But what happens is, this eculizumab is going to prevent body's immunity against capsulated organisms. So antibiotic prophylaxis and vaccination against meningococcus has to be taken. So that is about complement inhibitors of eculizumab. Next is combined liver kidney transplantation. See, when there is complement factor H mutation, which leads to reduced production of factor H, we know that factor H is produced in the liver. So what is to be done if combined liver and kidney transplant is done? Factor H is going to be produced and recurrence can be prevented. So if factor H is there, combined liver kidney transplantation can be done. Okay. So when it comes to transplantation in atypical HUS, living renated donor transplantation is contraindicated, and if it is factor H deficiency, combined liver kidney transplantation can be done. Now, this is the multiple therapies that is used in atypical HUS, their dosing and what is the efficacy. It can be classified into immunosuppressives that are given, fresh frozen plasma, liver kidney transplant and complement inhibition with eculizumab. So, immunosuppressive, it can be prednisone, prednisolone, immunoglobulins, that is depleting CD20 like rituximab. Prednisone is 200 mg tapered to 60 mg per day, then 5 mg reduction per week. Okay. It is probably, see, this table is common to both treatment of HUS and TTP. So, you will see the mentioning of TTP. This table again is taken from Feehally 6th edition, so you can refer to that. So, how it works is, it is probably effective in addition to plasma exchange in patients with TTP and anti-Adams 13 autoantibody, or in HUS where there is anti-factor H autoantibody. Okay. So, whenever it is an antibody mediated disease, so that is when this is going to be important, right. Next is immunoglobulins, also or IVIG is the same. Next, rituximab, which can be given in the dose of 375 mg per meter square per week up to CD20 is depleted. It is effective in the treatment or prevention of TTP associated with immune-mediated Adams 13 deficiency. Okay. So, wherever there is antibodies, then immunosuppressors can be tried. Next, it is fresh frozen plasma. Fresh frozen plasma, it can be plasma exchange or plasma infusion. Plasma exchange 1 to 2 volumes per day will be done first line therapy for HUS and TTP. Plasma infusion, unproven efficacy but can be tried in STC HUS. Cryosupernatant and also solvent detergent treated plasma, these two can be considered in patients where plasmapheresis is not or plasma exchange is not available. Okay. Third is liver kidney transplant. When there is factor H mutation leading to HUS, to avoid recurrence post-transplantation, liver kidney transplant can be done. Perioperative plasma infusion or exchange and eculizumab is advised. Fourth is eculizumab, which has to be given weekly for the first 4 weeks, and then every 2 weeks it has to be given up to 6 months. Okay, mostly to maintain remission, lifelong requirement might be there. It has reported its efficacy in atypical HUS. Next, coming to thrombotic thrombocytopenic purpura. Okay, what happens? There is systemic platelet thrombi in the microvasculature. Okay, main components of this thrombus is platelet and von Willebrand factor. What happens is, this von Willebrand factor is present in the platelets and it is also present in the endothelial cell. Okay, so in a blood vessel, there will be endothelial cells, there will also be platelets. Okay, I am just drawing like this. So, there is going to be von Willebrand factor that is going to be secreted by both these things. Okay, these are stored in something called as Weibel-Palade bodies that are present in these cells. These are secreted as ultra large multimers. So, these are going to be secreted as ultra large multimers, which can go get deposited on the blood vessel and it can cause thrombosis. Now, to prevent this, body releases a serine proteases called ADAM TS13, which will break this. Okay, so it is going to break this von Willebrand factor and prevent thrombosis. So, what is going to happen? When there is deficiency of Adams 13, these are the proteases that cleave the von Willebrand factor, there is going to be thrombosis. Okay. Now, this Adams 13 is produced from the liver and its normal concentration in the body is approximately 1 microgram per ml. Now, this is a diagram that is depicting the same mechanism. In the platelet and in the vessel wall, there is going to be von Willebrand factor. Okay. Now, what happens is, once this von Willebrand factors are there, this Adams 13 should come and cut them, that is the serine proteases, and lead to release of this just dimers of von Willebrand factor. Okay. Now, in the vessel wall, if there is no Adams 13 and this is continuously getting deposited, platelet comes and gets adhered and aggregated and forms clots. So, this is the mechanism by which TTP happens. So, this microcirculation clot can happen in multiple organs, more so brain and kidney are affected. Now, etiology, it can be classified into congenital or acquired. Congenital are homozygous or compound heterozygous mutations in the Adams 13 gene. Acquired is antibodies to Adams 13. Now, apart from HUS and TTP, there are some other causes of TMA like cobalamin C deficiency, it can cause TMA, drug induced like ticlopidin and clopidogrel. The mechanism of this causing TMA is by anti-Adams 13 antibody. So, it is a secondary form of TMA. Similarly, blood or bone marrow or hematopoietic stem cell transplantation can rarely cause low Adams 13 level. Malignancies can cause. HIV again can cause low Adams 13 levels. and SLE, antiphospholipid antibody syndrome, all these depends on the specific underlying disease. So here we see many secondary causes of Adams 13 deficiency, which is mostly drugs, hematopoietic or stem cell transplant, malignancy and HIV. Okay. Now, TTP associated with Adams 13 antibody. Okay. Most common cause in acute primary case is Adams 13 antibody. This antibody causes severe functional deficiency of Adams 13. Mostly it is seen in drug-induced situation, like here where we saw. Most common causes drug-induced, that is ticlopidin or clopidogrel. It can also happen genetically, but drug-induced is more common, and antibodies will disappear on achieving remission. Now, clinical features. Prognosis in severe situations, it is better than in non-severe. See, non-severe TMA is generally because of secondary causes. Okay. So, the secondary causes itself can lead to death of the patient, like it can be some malignancy, it can be transplant causing GVHD. So, repeating, it can be malignancy, it can be transplantation. So, this HIV. So, all these secondary condition itself will cause death. But in severe cases, which is mostly because of the antibody formation, which can be mostly because of drug induced or genetic, it can be treated, and so the prognosis is better. So, inhibitory antibodies generally have severe manifestation and time to achieve remission is longer. Okay. And in genetic condition, generally it is in the neonatal period it is seen, or in the third decade. It has two age groups in which it is commonly seen. One is in the neonatal group, one is in the third decade. And in genetic, it just means that the Adams 13 is deficient. The level is less than 1% of the Adams 13 generally. See, Adams 13 level, when it reaches to less than 1% of normal, is when all these problems occur. So, in genetic, generally it is going to be less than 1%, okay, which especially in the neonatal period. So, these patients have to undergo chronic plasma infusion. Now, treatment is plasma infusion is the cornerstone of therapy in this patients. Why? Because plasma has this Adams 13. So, you are going to replace plasma. So, you have to replace only till 5%. So, two important numbers we have to learn. First is less than 1% of Adams 13 level only patient becomes symptomatic. Okay. And if it is more than 5% only, and while doing plasma infusion, repeating, and while plasma infusion, our target is to achieve 5%. Okay. Now, next is, if there is a deficiency, then there is going to be regular prophylactic infusion that is to be given every 2 to 3 weeks. Plasmapheresis is indicated if there is anti-Adams 13 antibody. And if there is anti-Adams 13 antibody, then we have to suppress antibody. So, just plasmapheresis won't help. Immunosuppression like steroids or rituximab has to be given. Okay. Now, drug-induced TMA, mitomycin is a common drug that can cause TMA. It is generally given in malignancy, and by the time mitomycin induces TMA, the malignancy is usually in remission. Similarly, quinine, which is a drug that is used to treat muscle cramps, can precipitate TMA. Interferon alpha, which was used previously in treatment of hepatitis, also can precipitate TMA. So, mitomycin, quinine and interferon alpha are the drugs which can precipitate TMA. Finally, coming to the high yield questions. Types of TMA, we know there are two types, HUS and TTP. Most common cause of HUS is Shiga toxin associated HUS, which is mostly seen in children less than 5 years of age. Antibiotics in HUS is contraindicated because when we give antibiotic, it is going to destroy the bacterial cell wall and lead to further release of toxin into the circulation. Hence, it is contraindicated. Another thing is plasmapheresis is contraindicated in Streptococcus pneumoniae induced HUS because plasma infused can give anti-T antibodies, okay, fresh anti-T antibodies. Next, most common mutation in atypical HUS is complement factor H, okay. The type of atypical HUS with best and worst prognosis. The best prognosis is membrane cofactor protein. Worst prognosis is complement factor H. Type of atypical HUS with most recurrence and least recurrence. So, most recurrence is again complement factor H and least recurrence is membrane cofactor protein. Another important thing is the type of HUS for which plasmapheresis will not work is membrane cofactor protein. All these high yield questions have been asked multiple times as MCQs, so please revise this section before exam. So, in membrane cofactor protein, the plasmapheresis is not going to work. Thank you, friends.